express special thanks to Professor Chen to have me opportunity here. So today I'd like to talk about immunotherapy and the metastatic renal cell carcinoma. This is the COI. So I think you may be tired of looking at just figures, but still I'd like to tell you. There is a two phase there where the immunocheckpoint plays a very important role in the cancer immunotherapy cycle. The first phase is a primary phase with the dendritic cell activated T cell. In this phase, the CTLA4 and B71 interaction and PD-L1 and PD-1 interaction is important. And the other phase is effector phase, where the T cell is migrated to the cancer cell and attacks the cancer itself. In this phase, the PD-L1 and PD-1 interaction is important. But in the primary phase, it is mainly the CTLA4 plays an important role. The ipilimumab anti-CTLA4 antibody inhibits the interaction and prohibits the co-stimulatory signal from the dendritic cell to the T cell. In the effector cell, there is a nivolumab, is a anti-PD-1 antibody. It's a blocked interaction, so the block inhibits inhibitory signal between the two cells, and if T cell can attack the cancer cell. So today, this is the agenda of my talk today. The first one, I'd like to talk about nivolumab, mainly from the CheckMate 025. And also I'd like to show you the ipilimumab from the CheckMate 214. And also we have the Japanese subgroup analysis of a CheckMate 214. So we have the similar racial background between Japanese and Taiwanese patients. So I think our result is very helpful in your treatment. And finally, I'd like to talk about the role of PD-L1 as a biomarker. I think we can talk about this issue in tomorrow's afternoon with Dr. Chen in the urothelial carcinoma. But today, I'd like to talk about this role. So let me start with the nivolumab. So as you know, the nivolumab is the first immune checkpoint inhibitor available and became available in MRCC. It inhibits the PD-1. And according to the CheckMate 025, there's no difference between the two agents in a progression-free survival, but we're looking at overall survival. There's a significantly longer overall survival by the nivolumab. And this is a comparison between the Japanese subgroup analysis and the overall global data. The nivolumab, it shows this blue line indicates the nivolumab data from the global study. This light blue line indicates the nivolumab survival curve from the nivolumab in the Japanese patient. So Japanese patient shows a higher overall survival compared to the nivolumab. But for some reason, there's no difference between everolimus and nivolumab. This is one of the reasons, but a possible reason is the nivolumab group include more unfavorable patients like liver metastasis and poor risk patients. So that there is a big bias in the patient background in the Japanese subgroup analysis. But according to this data, the nivolumab is now the gold standard after the first-line TKI, and according to these guidelines. This is our data from the Tokyo Medical University. So it's a real-world data. We have treated 70 patients with nivolumab in the sequential setting, and progression-free survival is 6.2 months, and overall survival is 26 months, so very similar to the reported by the CheckMate 025. So the similar efficacy was obtained in the real world. Actually, I would like to show you the one case is a nivolumab, who showed durable response. He developed multiple liver metastasis during the treatment of the first-line therapy with the sorafenib. We started with nivolumab. After 2 months, the liver metastasis shrunk dramatically, and this response was just sustained during the 48 months then when the patient developed a new region in the liver metastasis. So the nivolumab showed a very good response in the metastatic renal cell carcinoma at the second-line setting. So let me move on to the ipilimumab. So as you know, the ipilimumab, the CTLA4 antibody, is developed used in melanoma first, but in the renal cell carcinoma, the ipilimumab is not used as a single agent. It is a combination with nivolumab. So in this study, the 3 milligram per kilo nivolumab plus 1 milligram per kilo ipilimumab was given every 3 weeks for 4 times, then followed by the 3 milligram of nivolumab every 2 weeks, and compared to the sunitinib. This is a patient background, and the intention treat, so it means all patients, and this is intermediate poor risk patient. There's no big difference between the groups according to these parameters, but it's also natural because those are randomized study, so there's no big difference in the background. And this is objective response rate reported in New England Journal. So for if you're looking at the intermediate poor risk patient, intermediate poor risk patient, objective response rate is 42% and from the combination, whereas 27 patients showed response in sunitinib, so this is a significantly higher response. But unfortunately, in favorable patient, the objective response rate is higher in the sunitinib. And also, there are 9 patients showing the complete response from the nivolumab and ipilimumab patient, which is much higher than the sunitinib. This is one of the characteristics that we can see, and this combination. There is a report. The report is this data is reported in the last ESMO, which is the follow-up period was extended to 30 months from the 17 months, and actually the CR rate is increased from 9% to 11.3%, and also in the favorable patient, and the objective response rate from this combination was increased from 29% to 39%. So maybe this combination is also effective in a favorable patient. This is the progression-free survival, which is a co-primary endpoint of this CheckMate 214. This is numerically, this combination shows a longer PFS, but it hasn't met to statistical significance because this CI is just beyond 1, so this is not met to the statistical significance, but still the longer survival. But overall survival shows the statistical significance, shows the big difference, and this combination group doesn't reach to the median level, so this is the difference that reach to a statistical significance. And also, the one big thing is when we're looking at subgroup analysis, this odds ratio of the overall survival is much higher in a poor risk patient compared to the intermediate risk patient. So I think this combination is more effective in a poor risk patient compared to the conventional therapy like a sunitinib. So, and also the intermediate patient is also a good response, but if the intermediate patient who is more likely to be poor risk is more fit to this combination. But treatment-related AE, actually, which related to the discontinuation, is a little bit higher in this nivolumab and ipilimumab, which reached to the 22% compared to the sunitinib at 12%. So this is one of the reasons why we have to be very careful. And this is the detail of the immune-related AEs, and this square indicates the AE showing the more than 10%. Actually, the rash, diarrhea, hypothyroidism, those are were highly observed in the higher incidence. And hepatitis is only found in the 7%, but most of them are grade 3 or 4. So the hepatitis or liver dysfunction is also one of the AE we have to be very careful. So according to the CheckMate 214, this combination is currently the standard regimen for the intermediate and poor risk patient. This is let me introduce one case of the CheckMate 214. This man came to the hospital with a lymph node metastasis and underwent cytoreductive nephrectomy, and pathological results show the clear cell was including the 20% of sarcomatoid feature. And he was treated on nivolumab ipilimumab combination, but after 4 cycles, he developed adrenal insufficiency, which is immune-related AE, and steroid hormone was replaced, but the nivo-ipi therapy was discontinued. This is a CT scan. This is a baseline CT before starting this therapy. He had lymphadenopathy and retroperitoneal, but it's gone. It's still gone after the 3 years. he has not studied the second therapy yet, but still this response is sustained. So then I'll move on to the Japanese subgroup analysis, the checkmate 2 and 4. This is the background slide. This is a global. This right two columns shows the Japanese patient, and it's similar to the subgroup analysis of a checkmate 0 to 5. This Nivo-EP group includes more unfavorable patients, like a poor risk patient is higher than sunitinib, and more patients who had multiple metastasis, and more patients with liver metastasis. So the patient background has a bias. But if we're looking at the objective response rate, and for intermediate poor risk patients shows a 38.7% of response rate, which is very similar to observed from the global study. So the similar objective response rate was observed in Japanese patient. If we're looking at the progression-free survival, there is no big difference between two groups in Japanese patient. And overall survival is the same. There is no big difference in the two groups. But as I told you, there is a big difference in the background. So we have to be very careful to interpret this data. So this is the change in the target tumor burden, which is a spider plot. I think we can divide the patient into two groups, this Nivo-EP group. Some group of patients showed very nice response and very quickly, and those responses very sustained in a long time. So this is a very big difference in sunitinib. Sunitinib showed include a very variety of patients. So the ipilimumab nivolumab showed the shorter time to respond, and also some patients showed a very nice response for a long time. When we looked at the adverse events, the incidence of discontinuation due to the treatment-related AE is a little bit higher in Japanese group, 32%, compared to the global reported in the global data, and 22%. So the incidence of discontinuation was higher in Japanese patients. So we have to be very careful in AE treatment. But we have to emphasize that 76% of the patients completed a full cycle of the ipilimumab in Japanese patients. So this is the immune-related AEs. So this red square shows the AE which is found in higher incidence in Japanese patients compared to the global. So the diarrhea, colitis, hepatic, and ILD, and skin-related AE is observed in higher incidence compared to the global patient. But for some reason, endocrine and AE related to endocrine is not frequently found in Japanese patient compared to the global patient. I don't know the results, but the results are results. So nivolumab ipilimumab for Japanese patients shows this similar objective response rate to the observed in the global study, and a similar AE profile despite of the little higher incidence of discontinuation. So I think that this combination is effective in the first-line therapy for Asian patients as well. So finally, I would like to discuss about the role of the PD-L1 expression as a biomarker. So this is the data of the checkmate 2 and 4. They divided the patient according to the PD-L1 positivity. Actually, the patient showed the positive PD-L1 showed the higher objective response rate at 58% compared to the patient is negative to PD-L1 who is showing the 37%. So there is a big difference in the objective response rate. So the PD-L1 it may be a good biomarker for the predictive for the response. And also, if we're looking at the progression-free survival, patient negative to the PD-L1 showed no difference between the two groups, but patient with positive PD-L1 showed, in this patient, and nivolumab ipilimumab showed a higher progression-free survival. So PD-L1 expression is a prognostic for response. Actually, if you're looking at the overall survival, this one is a patient with patient negative without a positive PD-L1 expression, but still there is a higher overall survival in the nivo and ipilimumab combination patient. But in the Tsunenori patient, PD-L1 positive patient showed lower overall survival because this PD-L1 is one of the prognosis marker for the survival. But in the this immunotherapy patient, these positive patients showed a higher response, objective response. So this indicate PD-L1 positive patient showed a better response to this immunotherapy, so it can be a good marker for selection. But same thing is can be found in other studies. This is Emotion 151, which is a combination in this study. The combination with the atezolizumab and bevacizumab was compared with sunitinib. And if we're looking at all patients, there's no difference. But if we focused on the positive PD-L1 positive patient, the difference is reached to the statistical significance. This is similar in the Javelin Renal 101, in which avelumab and plus axitinib was compared with sunitinib. In all patients, there is a still difference, but in the patient with a positive PD-L1, the difference is get bigger. So the longer PFS is observed in the PD-L1 positive patient in these two other studies. So I think that we can say the PD-L1 expression seems to be predictive marker for the response of immune checkpoint inhibitors. But the current issue of the PD-L1 as a biomarker is a kind of antibodies and evaluated cells are very different in each trial. There are the 5 trials in the testing in the first line. They use a totally different antibody, and the evaluated cells are totally different in each study. So I think the standardization of the antibody PD-L1 is necessary. For the future, I think the systemic therapy will be done according to the precision medicine. So we need the selection of the patient. So one is the IMDC score is one of the possible risk factor, and also PD-L1 testing is also important, and also we need other biomarkers. But we definitely need a biomarker to select the regimen. So in conclusion, immunotherapy with immune checkpoint inhibitors are becoming a mainstay of a systemic therapy for metastatic RCC patients. And nivolumab, ipilimumab is currently a standard regimen for first-line therapy for Asian patients as well. And exploring biomarkers is necessary to achieve precision medicine in metastatic renal cell carcinoma. Thank you very much. Thank you for attention.
Thank you.